Well, welcome. We're excited to have you both here. We're going to talk a little bit about our satellite clinic program that we have at UCLA. So Amanda's going to talk about the LGBT program, and I'm going to talk about the athletic satellite program. You want to get started with LGBT?
So the history of the LGBT satellite clinic dates back to about 2011, which is when I came on board at UCLA, as well as there was a change of leadership at the LGBT Campus Resource Center. Together with the hiring of myself and some other LGBT identified therapists, as well as the change in leadership at the LGBT Center, something that CAPS had long had in mind, which is to partner with the center for a satellite clinic, was able to kind of come to fruition. And so that's something that has been developing over the last almost 5 years.
And in terms of athletics, we formerly had a program director, Bob Korb, who is a sports psychologist who really worked on developing the athletics program. And one of the reasons, when he retired, actually, we decided to sort of transition the program into a satellite clinic, because what was happening is he was sort of the main point of contact and was kind of going over to athletics and consulting and sort of picking clinicians out to work with the student athletes. So there was just so much work involved, and it wasn't done in a streamlined way. And athletics was really relying on getting sort of hand-picked clinicians, which was creating a problem for us, because then we were trying to maneuver people into our schedules, and it just wasn't really fair the way in which it was sort of happening for them. We didn't have a really good system, so that's why we tried to create sort of the theme we use is a different lane, a new lane on the 405, and there's still congestion on that lane, but we're trying to sort of create a way for student athletes to get in to access services and reduce some of the barriers, and also to work with our partners in athletics.
So kind of using a socio-ecological model of prevention, I'll be talking about how we use our satellite clinic for primary, secondary, and tertiary prevention. We are really lucky in that the space that our campus has for the resource center does have an extra office in it with a door. So we are able to, there are some offices that are cubicle-like. It has a ceiling, it has a door, and we are able to, as a result, see students in a very confidential manner. And so our satellite clinic is truly a clinic outside of our CAPS building.
Oh, sorry. Do you want me to do it?
I can do it.
Take it over.
Yeah. So thinking about primary prevention, we do a lot of training with our student leaders as well as our professional staff at the center. In addition to our director, there are 3 other professional staff at our center, at our LGBT center. So one thing that we do is we provide mental health first aid. There are 3 of us on campus who are trained to provide that 8-hour training. And so we encourage our student leaders as well as the professional staff to participate in this certificate training. Additionally, we do QPR, suicide prevention training. It's about 2 hours. And every year I do that training with the student staff at the LGBT Center, as well as the interns and any student leaders, or in fact students who want to participate. But it's a training that takes place in their center, in their environment, and that tends to be a little bit more tailored to suicide concerns within the community. Additionally, we do that. Yes. No. Maybe you should do it. I don't think I am close enough. Additionally, we do tabling at events. Oftentimes, these might be our trainees or our administrative support staff who do the tabling, so it's not to take away from clinical time. But some of the examples are we have a Cookies and Queers event, which is our week 0 event where it's free cookies and just anyone's welcome to come in. It's kind of an open house, free queers as well. Our Welcome Home Resource Fair, which the LGBT Center puts on, and it has a number of resources throughout campus, including CAPS. Ally Week, which is put on by the students. We have a table at that. We are also simply present at some events. So our Lavender graduation, we're oftentimes just present there in attendance or presenting diplomas. I've been fortunate, as well as Carolyn from UCI, to be the therapist on the Hill for T-Camp, which is a weekend retreat for college students who identify as trans, genderqueer, non-binary, to meet each other. Given that this is a small community, being able to come from across California and meet others who share this identity is a real benefit. I'm also present in the center during the summers. I'm one of the folks who does not go on furlough, who is a therapist at the center, and we have a Sundays on Tuesdays event that the center co-sponsors with other campus partners, and so I'm there often to just inform our campus partners that there are CAPS counselors there at the center, that we do have a presence, as well as to meet the students who come in for free ice cream and let them know. And I get free ice cream every week. We also do a lot of sexual assault prevention. We host, in our campus calendar, we host events at the LGBT Center for IPV Awareness Month, as well as Sexual Assault Awareness Month. And with the new hiring of our Assistant Director for Care, Sexual Assault Resources and Education, Zabi, we did steal her from UCI, and we're very, very fortunate because she's amazing. Some of the mandated programming that we have to do, we're working to tailor much more closely to the needs of the LGBT student population, including to inform them how Title IX really applies to them in terms of harassment based on their gender identity or sexual orientation. In terms of secondary prevention, we have Queer Chats, which is a 1-hour weekly moderated drop-in discussion group that occurs on Tuesdays. And again, as I'm a therapist who's there on Tuesdays, it's something that I moderate. It happens over lunch, so it's kind of like a brown bag discussion, very informal. The topics are identified each quarter by students, and they range in everything from intersections of Black and queer identity to queer style. Often the topics reflect campus events such as IPV Awareness Month, Asexuality Awareness Week, which is more of a national event, and they can also be malleable to current events. So last year we often kind of changed some topics so we could discuss the events in Ferguson, Black Lives Matter, and things that were going on that we couldn't have planned for. We also do workshops by request, although this is a very small part of what we do. The request generally comes from the professional staff at the center, not from the students, and so they don't tend to be very well attended. We've done coming out workshops or workshops on returning home for the holidays. And we also do consultation with professional staff. So if there's a student who is showing up at the center who's causing concern, we can provide consultation to them. We also provide consultation to student org leaders. The student organizations are not directly affiliated with our Student Resource Center. In fact, they have their own separate space outside the center on campus. But you know, they often need consultation on how to manage members who might be of concern, as well as getting some support around advocacy fatigue, which is a phrase that I learned from Carolyn yesterday. In terms of our tertiary prevention, this is often what we think of when we think of the satellite clinic, and that's the kind of the direct service that we provide. We have drop-in consultation hours. Each of the 3 therapists provide 2 hours of open time a week at the center, total of 6 hours. It sounds like it's an incredible gift that we have to have unscheduled time during the day for students to just come in as they see fit or they see a need. This can be used for consultation for concerns that may not warrant a full course of treatment. An example is a student I met with 3 times last year, half hour each time, talking about she just recently came out to her family, was about to graduate, wanted to move in with her girlfriend, And our discussion is focused on how she can communicate with her family. She's a first-generation student. Her parents are from China. So how can she communicate to them in a way that would help them to understand her perspective? Additionally, we talked about how she could find allies within her family. After 3 sessions, she and her mother had a really good heart-to-heart, and she nearly no longer needed to kind of come in and speak with me. And so that was someone who might have otherwise come to CAPS and waited a long time to see somebody because her concerns weren't urgent, and in that time, a crisis could have developed and become urgent. Sometimes what happens during drop-in hours is I'm speaking with someone and I think, you need therapy, you need counseling. And so I will make that referral from the drop-in hours. So our drop-in consultation may serve as a brief screening, which is what we call our triage that we do for every student who makes initial contact with CAPS. Or the brief screening might take place at CAPS under typical circumstances, during which time the student might request to see an LGBT-identified therapist or one of the therapists who has hours at the LGBT center. Intakes all do take place at CAPS just because of the access needed for some of our PNC forms. Do you have a question? Yeah. Mm-hmm. It's a really good question. So currently, what we do is a contact note in the person's chart if they're willing to give us their student ID number. Sometimes they're unwilling, and that is kind of their prerogative. It's what makes the barrier to care reduced. But as often as possible, we are documenting it. Mm-hmm. The contact note is not the best note if we feel like we're gaining the amount of information that would be gained at triage brief screening. We will use a brief screening note. So all of our intakes do take place at CAPS. Scheduled follow-up may take place either at CAPS or at the LGBT center. This is determined by the student's preference as well as their schedule. So I'm there on Tuesdays. If a student isn't available Tuesday afternoons, I can't see them at the LGBT center. It's just kind of the barrier to that. But also risk. I'm not going to see a student who's very high risk at the LGBT center. While it's very close in proximity to our CAPS building, it doesn't have the same amount of support where I can look out of my office and from side to side see people who can help me, easily contact our point psychiatrist. So I won't see someone who's high risk, and that's kind of the clinician's determination. Yes?
Do you have access to PNC individuals?
Yes, so we do, and that has...
So when you're seeing clients, then you can do your case notes.
Mm-hmm. Yeah, so I can do case notes. We also have a tablet so that they can fill out the CCAPs. So let's talk a little bit about the utilization and how that's changed over the years. It's important to note that in 2012, 2013, we had one and a half therapists kind of serving there. And so 2013 to 2014 and 2014 to 2015 is when we were fully up and running with 3 therapists. So those numbers don't necessarily reflect the need of the campus, but also what we had available for students. But you can really see that we are highly utilized. So we have the therapy contact hours are scheduled follow-ups that occur outside of the drop-in times. And so the consultation contact hours are the types of contacts we have during those drop-in times. We hold them as much as possible and do not schedule them in advance. We also offer therapy groups. We offer those at CAPS just because not everyone who's in a therapy group is out. And so we have a satellite clinic because for some students it's easier to walk through the doors of the LGBT center than to walk into the doors of CAPS. However, for some students it's really hard to walk through those doors and much easier to come to CAPS. So we do, and we have made the choice to have our therapy groups all at CAPS. And we have groups for gay and bi men, for lesbian bi women. These are not the best names, and if anyone has suggestions about better names, because it doesn't fully capture everybody who's in our group. So the lesbian bi women's group has someone who identifies as asexual. I like to call it the non-heterosexual women's group, but that hasn't made the official brochure yet. Our gender identity spectrum group for trans identified students. Yes?
We have I'm on the Santa Barbara
Mm-hmm.
True Selves group,
Mm.
and that name seems to ring for a lot of folks.
Mm-hmm.
Then we have to attach to it
Mm-hmm.
because we're experimenting with. We had a combined group. We're looking at a peer men's group.
Mm-hmm.
Had a couple variations,
Mm.
but the True Selves part seemed to really kind of do well.
Okay.
It
Yeah.
spoke to a lot of
Yeah, I like that. I like that terminology. We also have clinicians who can assist with transition-related concerns, so both psychoeducation that students can present to their health services provider and request a referral for endocrinology to start hormone therapy. We are able to write letters. I know that varies from campus to campus. With consultation, our clinicians are able to write letters. And that doesn't just mean the clinicians who are at the LGBT Center, but truly any clinician on our staff who has consulted and feels like a letter for surgery is appropriate. We also serve on a number of committees throughout campus about trans issues. So some challenges which have already kind of come up. This space and confidentiality. So while we do have a confidential space within the center, it's not confidential to walk into the center, to wait for your appointment while everyone else is eating their lunch, doing homework, taking a nap, and then walk into the office where everybody knows the CAPS counselor is sitting. So that's why some students don't feel comfortable using our services there and prefer to come to CAPS, which is much more of like an anonymous building and where we are located on campus. Emergencies and frequent flyers. We consult often with each other through IM, the clinicians who do have time at CAPS, and how to handle those students who show up to every drop an hour. They often do already have a regular individual therapist, whether it's one of us or somebody else at CAPS or at our behavioral health service or in the community. And we talk about how to really both meet their needs, but also free up our time for students who might not otherwise be able to access us. PNC and documentation. We have a computer there that connects with our PNC system, and that's what has allowed us to see students there. Before we had that access, we weren't actually seeing therapy clients there. The expectations of our campus partners. Our LGBT Center staff love to say, both to students and people across campus, there's free and available counseling for LGBT students. Just come on in, just go see Amanda. And we've really been trying to shape them around what we provide. Drop-in is not counseling. Those are not students who've signed any informed consent. They've not been taken into our system officially. To really help them to understand the difference between consultation and counseling, although there's sometimes some overlap in what that provides. And to also say that it's not just doors open, anyone come in, and that they might have students that they want us to see, but for reasons that are related to their treatment plan, we can't see them in those drop-in consultation hours because they have a treatment plan with another provider, and it's going to cause splitting to see another therapist during drop-in hours. So that's in the campus partner side. The CAP side is the balancing of time between, we have unscheduled clinical time, basically, that cannot be taken by anybody else for our drop-in hours. That's a luxury. We are very heavily utilized on campus. We are carrying huge caseloads. We are overbooked, booking into office work hours, booking into lunch, and for 3 clinicians to have 2 hours each a week, where those hours might go unused is really a luxury. We've been fortunate in that our leadership has seen the benefit to the campus to have that open access to clinicians. And so the cost to our clinic of those hours not being used is still weighed out by the benefit to our campus of having those hours advertised. Another challenge has been, so we have a lot of mandates on our care programming, our sexual assault prevention programming, and thus far it's been kind of a one-size-fits-all, even though we're aware that that's not the best way to present. We've gotten a lot of mandates very quickly, and most of those mandates have fallen to CAPS staff on our care team, and that has burdened us. So we're just now beginning to tailor some of our sexual assault prevention programming to the LGBT student population. And Zabi, who I mentioned, has been remarkable in being able to do this. We want to broaden the reach of our mental health first aid and QPR trainings. So the QPR training is mandated by the center for their student staff, but I would really love to reach more than just the students who work in the center. And our mental health first aid is new to our campus, but I'd also love to see that kind of be more heavily utilized by LGBT student leaders. And then, another challenge is collaborating with campus partners around trans and transition-related concerns. There's a lot of things that our clinicians would like to see happen that are slow-moving, including getting a gender-neutral restroom at our CAPS building. We kind of have one. It's not great, though. We have like a temporary sign over a women's room sign. That's not really a gender-neutral restroom. As well as we don't have a gender-neutral restroom in the Student Activities Center where the LGBT Resource Center is located. So we are doing a lot of advocacy, and as you all know, the UC system can be a slow-moving machine. I'm going to turn it over to Melinda to talk about athletics.
All right. So in terms of athletics, I'm going to talk, as Amanda did, about the ways in which we do primary prevention, secondary prevention, and tertiary prevention. So I'll talk a little bit about our outreach, our staff training and education, sexual assault prevention, and then our student athlete mentors program for primary prevention. I'm going to talk a little bit about the ways in which we do clinical consultation for secondary prevention with athletic staff, and then I'll talk about our satellite clinic for tertiary. All right. So in terms of outreach, Amanda sort of alluded to this in her presentation. One of the things that's been really challenging for us this year and in the past, I would say maybe 5 years, is just the utilization rates and our ability to provide outreach. I think with regard to the athletic community is sort of limited, because I think what we're trying to do is prioritize more of the clinical work and the consultation. So we do still provide outreach by request to teams. Oftentimes concerns come in around body image, disordered eating. We've had some concerns this year around coping with loss and helping a team sort of manage that, either a loss of a teammate or a loss of a family member of a teammate. So some loss grief work, and then managing stress around academic life. So we will do outreach by request. Our athletic program also, I believe, hires psychologists from the community to do some work with their teams. So we're kind of lucky in that they fund that on their own and separate from CAPS. And then other things that we do provide are things like Bruin orientation. So when the freshman student athletes come in, we partake in their orientation and talk to them about CAPS services as well as the Student Athlete Mentors program. And then we do a yearly wellness fair for student athletes, and we kind of rotate different teams coming in each year. And we partner with academic staff in athletics to do that program. So again, we'll do some mindfulness, kind of present them with information about CAPS, and just we host it at CAPS. So we're trying to just, again, like reduce barriers and get them in our doors. And then we provide staff trainings. So in terms of staff education and training, as Amanda said, we now have mental health first aid, which is really, really great. And what we're trying to do is provide our athletic staff, all of our athletic staff, if possible, with the mental health first aid training. We just did our first round, which went great. Basically, what we've seen in the past year in particular is we've seen really high acuity, and those staff have been really impacted. So they're seeing, students who need to be hospitalized, who are coming in with, some, features of psychosis, and they're really struggling with how to manage that. And so we've been really trying to give them more training and more education and really support them and empower them to sort of know what to do and know when and how to consult with us. So that's been really useful. So Amanda went over mental health first aid, but basically the training talks a little bit about recognizing signs of mental health problems, how to offer and provide initial help, and then how to guide a person toward appropriate treatment and other supportive help. I think it's been really useful more recently is to get our athletic community into the mental health first aid training together so that they can address and ask some questions specific to their population and specific to what they've seen. So they're also getting training but some support around how things have gone in the past year. So we are trying to kind of expand that training in the coming years. Yep.
So is the training to lay people is 8 hours long?
Mm-hmm. We do separate trainings for staff and faculty from the student training. So we'll do student trainings and staff and faculty trainings, but we purposely separate them because of the issues that might get raised.
We also do QPR, and this is something, again, things have been so busy for us. I'm sure you guys are feeling the same way, that oftentimes it's hard to just think about, like, as staff rotate in for athletics, like how many people have actually gotten the QPR in the past, couple of years, because we were doing it sort of yearly for a while. So it's something that we're really trying to track and make sure that all of their new staff get trained on QPR. And that includes mostly the athletic trainers and the academic staff. So as you all know, QPR is a suicide prevention training. The other training that we did in this past year is talking about the role of the athletic trainer in the mental health of student athletes. One of the things that we've seen and realized is that our athletic trainers are really on the ground with these students. And we're actually pretty lucky because in athletics, they know everything about these students, including like when they wake up, what time they eat, who they're friends with, what they're doing on the weekends. So we get a lot of information from our athletic training staff, but we've had to really help them think about like what their role is, think about boundary setting, because they're often texting with students. And we've had some cases more recently where students were in crisis, for multiple crises throughout the year, and sort of texting the athletic trainer in the middle of the night, stuff like that. So we've helped them to try to think about how to manage that, how to work with the therapist and the team, and really thinking about what their role in promoting mental health for students is. And that, I think, has been really helpful, and it also just got the dialogue going and helping them to sort of reach out and get some support. We also do our care certificate program. So we had a mandate in this past year that required us to provide the sexual assault prevention and education to all of our 24 teams in the fall quarter. So that happened very quickly. So one of the things that we aspire to do, as Amanda's saying, our care programming, now we have a little bit more support. What we're trying to combine that program with our SAMs, our Student Athlete Mentors program, and those are an identified group of student athletes who want to promote wellness for the athletic community. And in the past, we've had our Student Athlete Mentors help facilitate our sexual assault prevention training. So 2 of our SAMs work with one of our CAPS staff, and they go in for each team and co-present. And we really like that model because it's the peer-to-peer education model, and we feel like they've given us really good feedback and they can help tailor the presentation to their community. So we're hoping to do that more in the future. In this past year, it's been really tough because the mandate was so quick and we had to kind of move and act, and it takes a lot to kind of coordinate all the services. All right, so I'll talk a little bit next about our Student Athlete Mentors program. So basically our SAMs, we have about 18 SAMs members, and they self-refer in, or they're encouraged by their coaches or their athletic trainers to join the program. And basically they serve as resources for teammates regarding wellness and mental health concerns. They serve as liaisons between athletics and CAPS. And they also serve as role models and promote a culture of wellness in the athletic community. So they receive education and training from our CAP staff. So they get care certified, they get QPR training, they get mental health first aid if we're trying to get them all mental health first aid if available for 8 hours. And then we do a lot of other trainings on things like body image and disordered eating, stress management, even sleep hygiene. So we try to really think about what issues are coming up for their teammates and help them think of ways in which they can disseminate that information to their teammates. One of the things that we've been really trying to do to build out this program in the past year is help them transition to a more student-led program, because in the past, historically, CAPS was kind of doing everything, and so we really want them to be taking the initiative and having them take ownership over their program. So we've tried to create a leadership panel for them and nominated them into certain positions. So we have 2 co-presidents, and we have a couple members who participate in oversee, like we have a marketing director, we have someone who takes a lead on recruitment, and then someone who's sort of the point person for each of our programs. So someone who's a point person for our RAD event. So that's been really helpful, because I think it's really it's increased their accountability and their participation, and they're becoming more and more involved. And what we do is we attend they have about 3 meetings a quarter, and we attend all of those meetings. We provide education and training, and then we meet with the co-presidents and we mentor them around how to build out this program. The other nice thing is that we do get some support from athletics. So athletics kind of they fund dinners for all of the events, and then they fund things like T-shirts and prizes and things that we'll give out and the events that we're tabling. So some of the programs that we did in this past year is Poise Women for Women. This was a program that the student athlete mentors decided they wanted to do, and it was based off of an event done in athletics based off Sheryl Sandberg's Lean In book. Athletics ran an event for women, and the student athlete mentors decided that they wanted to run an event, and actually we had a great turnout. We had about, I think, almost 250 student athletes attend that event. We had coaches, we had speakers. It was really, really amazing, and just really brought people together. And the student athlete mentors really basically developed the program. They coordinated it. They facilitated discussion. They checked people in. Like, they did such a great job. So that was really exciting. That was probably our biggest event this year. And then we do a RAD event each year, which is the Recording Artists, Actors, and Athletes Against Drunk Driving. So we provide some information about substance use. We do tabling. Again, they got really involved. We had a lot of prizes that we gave out. We probably saw about 200 students come by that table. So that was a big event as well. And then they also participate in International No Diet Day. So they work with our interns and postdocs to table that event. Questions about that?
I have a question about something prior to that.
Uh-huh.
Just in general, how do you manage confidentiality with the students that you work with in the athletic department?
It's been really challenging.
I imagine coaches are high demand. They want to know what's going on with their athletes.
Yep. So what we do is, I can pass this around when I talk about it. Or, yeah, Amanda's going to pass this out. This is a brochure that we've created that talks about our satellite program. And in this brochure, we talk about communication between CAPS and athletics. And this goes to all of our athletic staff. So we really try to train our athletic staff about the issues with confidentiality. In athletics, they talk very, very openly about everything, and coaches are very demanding. We're very, very careful to maintain confidentiality with our coaching staff, and so we have really strict boundaries with our coaching staff, which is challenging. They get upset sometimes, they push, so it's just something that I think we're very strict and tight around. So for us, I think we know what our boundaries are, and it's just sort of like teaching and educating them about why we maintain those boundaries. We also, in our consultation in our athletic care committee meeting, we used to sort of look at that as a treatment team meeting between our team physicians and our CAPS counselors, but athletic trainers were also in that meeting. And so what we decided in this past year is to maintain confidentiality and only communicate with our team physicians one-on-one and just provide consultation in that meeting. So we no longer talk openly, even if we have a release to speak. What we used to do is we would get a release for the whole treatment team, and now we're getting individual releases. So one for the athletic trainer, one for the team physician. But because there's multiple people in that meeting, we now don't provide any information about the students that we're treating. It's been, I think, a hard shift for athletics, but I think it's been really important to protect the confidentiality of our students. It has been a little bit more burdensome in terms of that was a meeting where we could go and openly consult, and it was really useful. And now we're trying to figure out ways to consult. We do a lot of emailing back and forth with the team physician. So that's one of the things that what we're thinking about for next year is actually having a drop-in consultation hour, not for students, for staff, so that coaches, team physicians, or athletic trainers or academic staff could drop in and either provide information, get support, or consult if we have a release in that hour.
Is it actual email, or are you able to use IM and secure message with the athletic?
We can't because they're not on PNC, so they have a totally different system. So that has been a challenge. And we've really done some education around how to email in a protected way with them. So that's been useful. They've been really responsive. I think the lessons we've learned is just really communicating with them and helping them to understand why we do the things we do, also respecting their system, and then figuring out a way that we can work together that's still protective of confidentiality. So in terms of, let me go this way. In terms of secondary prevention, we do provide clinical consultation. So we do that in a couple different roles and ways. So I'm the athletics program coordinator, so I provide consultation for athletic staff. And then we also have a clinical coordinator, Dominique Gillis, who we recently brought on, and she does a lot of day-to-day consultation, and she manages the referrals. This has been like a life changer, a game changer for us, is having someone who's available to consult throughout the day. Because of her role, she has a lot more flexibility. And what was happening before is athletic staff were contacting myself or another clinician who are sort of the point people, but we're booked throughout the day, and you can imagine trying to consult in real time and manage these sort of more urgent or emergent referrals was really, really challenging. So having a point person who is actually available throughout the day has been really, really helpful for us, and I think has made athletics feel much more supported from CAPS. So Dominique does a lot of the crisis consultation, managing referrals, and then I'll do some of that as well, and then I do the program coordination work.
You do have a satellite clinic there as well?
So that has been something that's been a challenge for us. We initially started off with having the satellite program over at athletics, and they felt really excited about that, to have us there and to really get to know our staff. We have 4 clinicians who work in our satellite clinic, but we had a really, really tough time with logistics. So getting access to PNC, getting the computers up and running. Also, we were seeing people back to back. So you can imagine if you're seeing 4 clients back to back and not having the manpower to have people being checked in or getting their intake paperwork uploaded. We were trying to do that in between sessions, and we didn't have a telephone. So it was just really, really tough. So we actually, in this past year, decided to put our satellite clinic back at CAPS. So we still call it our satellite clinic, but we host it at CAPS. And then what we're trying to do for this year is we're going to have the consultation hour over at athletics. So the rationale for that is that it gives athletics some face time with our clinician. It provides more availability for consultation for their staff, and it also helps them get to know our clinicians, which what we've learned is that for athletics that's been really, really helpful, because they like to kind of hand their students off to people who they know. And so we're hoping that will help them get to know our staff a bit better. What else was I thinking about that? It's also been helpful in terms of, as Amanda was saying, one of the challenges with the LGBT Center is if those hours go underutilized, we're also thinking broadly about the cost to our clinic. And so what we've done is we hold 16 hours a week for our satellite clinic for athletics, but if those hours are not being utilized, we give them back to our CAPS clinic. So meaning we can see intakes or follow-ups from CAPS in that time. And that's been really important for us, just given the demand.
It's also important to note about funding is that some funding for the satellite clinic through athletics comes from athletics, which I think generally speaks to the amount of funding athletics has. We don't get any money from the LGBT Center. They don't have a budget that has any room for anything. So that's also some of the disparity in terms of the number of hours given to each clinic.
I would imagine it's a double-edged sword, though, because when they're providing money, they also have expectations.
Yeah.
I paid for it, this is what I want.
Yeah. And that has been our biggest challenge, is really managing our expectations. I think their expectations. I think in the past, the clinicians who really love this work jumped in. And so, of course, you want to do a great job. You want to, meet their every need. And they're also a fantastic team to work with. So it's both exciting, it's rewarding. But I think that's been hard, as we've been over-promising and then really struggling to manage it. So we've had to really openly dialogue with them around, what's realistic, reasonable for us, what we can provide, and then really helping them to think about how they can get services for their students elsewhere, and trust in those services in a way in which they feel supported and not like we're, kind of saying, sorry, we can't help you. So that has been really useful, and what has changed this year is that athletics has decided to kind of hire out people to do their alcohol and other drug programming, which we used to do for students who have like a first, second, or third positive test. They need assessment and intervention fairly quickly, and again, we've been scrambling to try to meet their needs, and so they've decided to partner up with the hospital to do that, and they're also thinking about partnering up with the hospital for long-term care for their students. So it's actually been really useful to say no and to dialogue with them and to help them understand why we can't provide some services, but again, to help them in a supportive way get those services met. So the Athletic Care Committee meeting is a multidisciplinary monthly meeting, and we discuss high-risk athletes. We do, the way in which we organize that meeting is we have level 1, 2, and 3. So our level 1 are our most acute, most severe students. Level 2 is oftentimes treatment planning, and then level 3 is sort of like updates. And so we've encouraged them to structure their meeting in that way to make sure that we're talking about the highest risk athletes. Our role as CAPS clinician is to consult, to facilitate referrals. We outreach to students, and then we also document on every student that's discussed in that meeting, and that's helpful if they're not a CAPS client, but they become a CAPS client in the future. We have a lot of information about what's been going on over time, so that's really useful for the clinician. And if they are a current CAPS client, we provide information from the athletic trainers and team physicians and the dietitian. And so we can give that to the CAPS clinician that's working with the student. So the people who attend this meeting are the athletic trainers, the team physicians, the team dietitian, CAPS psychologist, CAPS psychiatrist, and our CAPS clinical coordinator. So this is our CAPS at Athletics satellite program. We've kind of talked a little bit about this already, but basically the way in which we structure this program, again, we house the program at CAPS, and we talked about why we do that, why we decided to do that in this past year. So we hold athletic brief screenings at CAPS, and we actually encourage our student athletes to self-identify as student athletes so that we can help get them into our satellite hours and facilitate a quicker referral. We have intakes. We have emergent, urgent, and routine intakes that go into our clinic at CAPS, but also can go into our sort of reserved satellite hours for athletics. And then we do ADHD intakes and psychiatry referrals. So we have designated clinical hours. As I mentioned, we have 16 hours a week. So we have Tuesday mornings and afternoon/evenings, and then Thursday mornings and afternoon. And we have 4 clinicians on staff who want to do this work and are interested or have experience working with student athletes. As you can see, these are the clinicians. What we're trying to do is give our clinicians more contact with athletic staff, these 4 clinicians, so that they can really get to know athletic staff and develop a working relationship with athletic staff. That has been challenging because everyone's so busy. All right, in terms of utilization hours, we had 297 total utilization hours this year. So we had 149 scheduled clinical hours. We had 3 hours of consultation, 4 hours of meetings with athletic staff, 4 hours of outreach and prevention, and then 20 hours dedicated to the SAMS program. This is just in, again, those satellite hours, those 16 hours a week. So that's where we landed this year. So we saw a lot of students in those hours. And again, what we do is we give the unused hours back to our CAPS clinic, so that those hours aren't going unused.
Sorry.
Yep.
Question for you about that. So of these scheduled clinical hours, are those all for athletics? And
Yep.
So the remaining 130 plus hours, those were partially utilized by CAPS for other?
Yeah, they were partially utilized by CAPS, or there were some days where we had closures or clinicians weren't available because we had like intern training. So sometimes the clinicians' 4-hour availability goes to 2 if they have other obligations. We try to really be careful about that and reserve those hours. But yeah, the rest of them went back to CAPS for follow-ups or intakes.
Santa Barbara, we kind of struggle with, we have a number of satellite offices.
Mm-hmm.
This idea of drop-in hours and then advertising them. And so it says something to the community to have them advertised, and I think it makes a statement.
Mm-hmm.
And also, and then the clinician can do some follow-up or case management if people are walking in. So it does have some nice side benefits.
Mm-hmm.
So I've been trying to encourage some of the clinicians on our staff to collapse tasks into, that kind of view it as an admin hour as well as if you're open for business if someone walks in.
Mm-hmm.
I really like what you're doing with splitting the time back and forth, and we just changed over our sports psychologist person. We have a new one in there, and so we're kind of rebuilding the program.
Mm-hmm.
So this is kind of invigorating to kind of get this idea of mixing it up, having FaceTime over at athletics, but then actually having more of the focus being in a more confidential space.
Yep. Yeah, and it's just been smoother for our clinicians. I mean, you're in your office, you have papers that you want to give, you have everything available, you have support from support staff, versus trying to set everything up over at athletics was challenging. And I think one of the things, it was also sort of challenging to be over there for 4 hours, and if we were going unutilized, I mean, it was great to be able to like catch up on stuff, but it wasn't great for our clinic. And so to try to balance that, I think having that 1 hour a week consultation for staff, I'm really hoping that meets the needs of their staff and makes them feel like we're really available to them, and we have a chance to really get to know their staff and work with them, but also we're not giving up like 4 hours kind of over there. We're still able to use some of those hours for CAPS clients. So yeah, it's worked really well. No.
Can I ask either of you a question, either about athletics or about some of the career students on campus? We're also struggling with our CSGD to give them FaceTime, and then how do we make sure that because we're spread pretty thin.
Mm-hmm.
Yeah.
We're pretty short staffed. So I'm always looking at how can I kind of magically make multiple things happen at once. There's no
Mm-hmm.
we've been getting a little extra office space, but it's in these really random, weird pockets, and so I'm trying to turn that into a positive thing, like maybe private, in the corner. But so I'm wondering, do you think some of the athletes that you're trying to get in, their space time over at athletics is here as much of a barrier for athletes to come into the actual counseling center? Is there any benefit to say, That's what, so the residential office where grad students live has been very successful for the students. Grad students have this sense of privacy around that. So I'm wondering if it's worth advertising having small parents. We have a couple of these spaces, and there's no other affiliation really nearby other than the Veteran Resource Center next door. So any idea that it's a barrier to athletes?
No, I think one of the things that's a little bit unique about the athletic population is they sort of do what they're told to do. So if for the most part, if their team physician or their athletic trainer or their coach sort of says, like, we really want you to go to CAPS, or you have to go to CAPS for an assessment, they come, and so I think for them, I don't think it would be a barrier. I think it's more just around for the staff. For myself, having worked over at athletics and trying to sort of like run from CAPS to athletics and not having all the information and material that I'm used to felt really stressful and felt a burden to the staff. So I think if we were to think about doing that, probably like really setting that office up with kind of everything the staff needed, I think that would really be probably useful. I don't know how you feel about LGBT.
I in some ways, having like a little annexed room in the middle of nowhere might be useful for a student who doesn't feel comfortable coming into CAPS or the LGBT center. One of the benefits of being located in the LGBT center for my drop-in hours is that if by some miracle I'm both caught up on all my paperwork and there's nobody dropping in, yeah, it's a fantasy. It's a hangout spot. So I go and I sit with the students and get to know them. And, in doing so, they get to know one of the CAPS counselors. They can, if they're not going to utilize me, they can refer to their friends. Oh, I know Amanda. She's a great person. Yeah, it might be scary to go to CAPS, so just go talk to her. And so there's some benefit to just being present in the community. We're thinking about opening satellite clinics for the medical school and the law school, and those kind of annexed off in the middle of nowhere offices might be of most use for those students who really might not want their colleagues or future colleagues to know they're utilizing mental health services by either seeing the office that's at their school, if everyone knows that that's the CAPS office, or walking through the doors of CAPS where they might see classmates, or for the medical school students if they've sat in on something with an undergraduate or mentored an undergraduate.
Well, and geographically, both athletics and the LGBT resource center are very close to your office.
Yeah. So,
when you start talking about law school, that's on the other side of campus. Hiking up
Yeah.
Hill.
Yeah.
One of I think the biggest challenges in having a space that's sort of unaffiliated with the clinic is you have to have lots of logistical things in place. And if you have drop-in hours, there's a potential loss of clinical productivity if you don't have someone checking students in. We all get CCAPs as part of our initial intake or follow-up, and so there's no support, which makes it really challenging to get a student from point A to the office, given the paperwork. So we really struggled with thinking about how to build that into any of these satellite clinics. And we're asking the law school or the medical school to give us some support, which also gets complicated. Who is that person? Can they have access to student information? How much?
Well, there's a very real thing about safety, for the clinician that's not in the middle of nowhere.
Right. If an emergency were to come up.
Emergency arises.
We're centrally located from the LGBT center. I can walk a student over to CAPS really easily if they need to be seen emergently, and I don't have the time to do that, or I don't have the support that I need to do that at the center. It was a huge change when we got our tablets and the ability to administer the CCAPs at the center.
And I think this speaks to like one of the challenges that just probably we've all had, is trying to meet the needs of our community and do everything we can and think of these creative ways as to how we can meet the needs of the community, but then also really think of like, wait a minute, how does that impact us? Like, as I found myself like running from point A to point B and like dragging paperwork and like trying to log into a computer that I don't know, like it just felt like total chaos, and it was really hard. So I think it just speaks to this idea of like, how can we meet the needs but also be protective of our clinicians and our staff?
I just had the question about, it sounds like you're trying to service some different groups
Mm-hmm.
on campus, and the ways in which you optimize for those groups can vary. So I guess why technology is involved in that, and it would also service your needs of safety if you could have those communications, or the peers are involved in those communications. So is there a way to both leverage folks in the community and the peers with clinicians directly to sort of, is that kind of go-between using technology?
When I think about safety, I really think about like physical presence. So if I'm sitting with a student who's highly suicidal, the ability to call a psychiatrist who's on call into my office, or to have that student walk across the hall to see that psychiatrist, is very different than if I'm sitting in a different building, in a different part of campus. So actually, I think safety is less about technology often and more about the physical infrastructure that we have. I think we're getting
cued that we're out of time.
Kicked out. But feel free to contact either of us with more questions.
And I passed around our model of for our athletic satellite program, so that sort of shows all the services we have.
We have a similar document for LGBT, but it's still in draft form, so I don't feel comfortable passing it out at this time. But if you were to talk to me one-on-one, I can show it to you.
Thank you so much.
Thank you.